I am here as ever with Dr. Richard Scott, GP or family practitioner if you're in the USA. Hello, Richard.
Andy, good to see you again.
Yes, so I can't see you, but you can see me, which is fun.
As we mentioned earlier, that's probably an advantage.
Yeah, well, possibly. Right, so really quickly, we had a few people just saying, "Oh, we loved the interview with Dr. Richard Scott. They found it fascinating and interesting." Because we're exploring medical stuff together, aren't we?
Absolutely, and I have to say I'm learning as much as I'm giving out, hopefully.
That's really good. I'm happy to ask the simple questions, and you have quite a bit more ability to answer than I can, so that's great. Okay, so last week, just to recap, yes, just a smidge, we were talking about caffeine, we were talking about how long it lasts in your system, we were talking about the effects, particularly on frailty was one of the things that we picked up on, and whether caffeine helps people as they become older, will it make them less frail? And there were all these things we're talking about, and I asked a few questions, which you've gone away and you've done a bit more digging for. So shall we start by finishing off last week's, I suppose, Q&A, really?
Yeah, Andy, that sounds good. So yes, indeed, I actually wrote down 5 questions from last time, and I've got one little bit to throw at the end, and I'll tackle them all fairly quickly so we can get on to today's topic. But they were good, and the first one what you asked was, okay, I've mentioned that caffeine helps us reduce weight on exercise. So how? This has been studied recently, which shows that in the lean, the obese, and especially in the young, if we exercise, having had a strong cup of coffee an hour beforehand, we can lose up to 29% of fat, more than we would otherwise. So the coffee helps us to lose weight, the caffeine in the coffee. So how? And the answer is it helps with fat burning. So caffeine deliberately seems to improve fat burning, and thus you have it an hour before exercise and you burn more fat. And this came from the Journal of Sports Medicine and Exercise Metabolism, so a proper medical journal. Now, of course, there's a downside, which is if you stop caffeine, some people note that they gain weight. Because interestingly, caffeine can even help us burn fat at rest. So yes, we can do it on exercise, but actually even at rest, it helps us burn fat. So if you stop caffeine, you can gain weight. Why? Well, it seems to be that we need a sugar fix if we stop caffeine, because people like me I don't have sugar in my coffee, but I do have a cake or a biscuit next to it. Others put sugar in their coffee, maybe less than we used to, but it still happens. So we therefore crave a sugar fix if we don't have caffeine, and there we go, we put on weight. So, but the good news is, if you take your strong cup of coffee, on average, actually, it's about 15% gained in terms of burning off the calories if you really sweat properly. But it can be up to 29%. So there's some good news, caffeine before exercise. The second one we looked at was, how does caffeine help in frailty? And interestingly, Andy, I don't know if you remember from last week, I said, well, I would venture forward that some of these studies will have answers why and some won't. And here's the one that doesn't. All the study has shown is it helps in frailty, and considerably reduces hospitalization, disease, falls, but they don't know why as yet. So no doubt that research will be followed up. So it helps, but we don't know why. That's number 2. Number 3, how does caffeine help our heart? Because there's no doubt that caffeine helps in reducing cardiovascular mortality, which is, of course, the number 1 killer. And the statistics and the journals state that filtered coffee, which is where the study was based, reduces heart failure, it reduces high blood pressure, and it reduces atrial fibrillation, which is, of course, interesting to you, you've mentioned radio in the past, you've had atrial fibrillation. How? Well, it reduces atheroma. Now, atheroma are the fatty plaques in our blood vessels, which further up our blood vessels increases our high blood pressure because the heart has to work harder to push blood through further up vessels, a bit like a narrowed tube, and thus that leads to heart failure and also affects atrial fibrillation. It also increases good cholesterol. So many people will know there's 2 types of cholesterol, if you like. Bad cholesterol, which is HDL. That's the HDL is the lipoprotein that deals with cholesterol, and you have good HDL, which is the high density lipoprotein, and you have the bad one, LDL. And HDL, the good guy, is increased by caffeine. So there we are, two reasons, atheroma and HDL, they're strongly linked. So caffeine does seem to reduce cardiovascular mortality by a direct effect on our blood vessels.
That's amazing.
It is. It's very helpful. Number 4, what about Parkinson's? Well, Parkinson's is a nasty disease. We know, I mean, we classically see it with the tremor that people come in with, but it also makes people more rigid and disturbed gait. And why? Well, we have these specialized neurons, brain cells, called dopaminergic neurons that produce dopamine. So dopamine is a helpful neurotransmitter in our brain. And when these cells get damaged in Parkinson's, they produce less dopamine, and then you get the Parkinson's disease. Now, it's a bit complicated, but essentially what I learned in looking it up is that you have 2 types of neuroreceptors next to each other, those that deal with adenosine, another neurotransmitter, and those that deal with dopamine. And what seems to happen is that caffeine blocks the adenosine receptors, which then leads the dopamine ones to be stimulated more, and thus produce more dopamine. So by blocking one receptor, it allows the other one to be more effective, more efficient. And therefore we get more dopamine and less Parkinson's disease. So there we are. That's my particular bit of learning today, these receptors next to each other. So there is some science behind why caffeine works in Parkinson's. So that's good news.
It's fascinating.
It is good stuff, isn't it? And the final question, you said, you mentioned 60 plants or more that caffeine's found in. We'll name some of them. To be fair, most of them are different varieties of coffee and tea plants. We also mentioned cacao, from which we have chocolate. Interestingly, caffeine's also found in the flowers of citrus plants, apparently, lemon, orange, grapefruit, and some things that I hadn't really heard of much before, yerba, guarana. So maybe people who are into these things will know more about those than me. So it's found in a lot of different varieties of plants, but particularly coffee and tea plants. And so the question I then asked myself was, okay, why do plants produce caffeine? And I think there's 2 reasons. One is if you like, there must be something in it for the plants as well as, because that's how God's designed nature, is that it works for both sides. One is that the bitter taste puts off some animals that would otherwise eat their leaves. But the second one is that many of these caffeine-containing plants, their major adversaries are insects and fungi. They're the pests that will damage the plant. So the plants, if you like, have got to fight back. And the way they fight back against insects is through producing caffeine. And insects that eat the plants get a high dose of caffeine. And this really affects them badly. They get CNS, their central nervous system is badly affected. They get paralyzed and then die. So caffeine is the way the plants defend themselves against insects and fungi, as well as producing good effects for us. So yeah, it's as ever in God's design, there's quite an intricate ecosystem, and it's got good effects, and it also helps to protect it from pests. So there we go. Learned a few things.
I love learning stuff. Every day's a learning day. I say that a lot, and I mean it. But I love the fact that plants are protecting themselves from insects, but it's good for our hearts. It's like God had a plan. Do you know?
Yeah, and people who say, creation's an accident, or rather, this world is an accident. There's so many accidents out there. I just can't believe it. It seems to fit with a picture of an intelligent designer. And there you go. There's another, if you like, string to our bow on that one, I think.
Yeah, absolutely. The Parkinson ones, that actually makes some sense to me. I don't do science very well, but that one actually makes sense. If you suppress one thing, then something else is going to come up in its stead. So I can understand that one. That's really interesting.
And there will be much more complicated science than I've summarised there. But yes, that's essentially it. From our point of view, I think that's what we need to know. There is some science behind it, although in frailty, we don't yet know. It's simply a finding, but query why. But obviously, they'll find the reasons in time.
Yeah, I think my idea last week was, could it be to do with the fact that with caffeine, you might be doing more exercise and therefore building up some sort of, I suppose, store of better energy elasticity for later in life. But I'd love to find out when that comes out, what they find out. That's great.
The great thing about science is you have a hypothesis and then you have to prove it. Yes. And you either prove it or you don't prove it. And sometimes along the way, and this is, I think, the fun in science, people discover stuff they had no idea about. And then it leads to further science, doesn't it? So, we'll discover in time.
The other one that I wanted to pick on was the good and bad cholesterol and caffeine, because there's all these things about what you should eat and what you shouldn't eat. And here's this miracle new man-made thing that's going to fix cholesterol. but actually coffee from plants, which God made, is good for your heart, which is it's brilliant.
It is good. It is good. Yeah. I mean, there's no doubt that statins is what we use to reduce cholesterol are hugely effective. So there's no doubt the medication is massively effective, but very nice that there are some natural remedies as well.
Yeah, and it's funny when I said to people, "Yeah, but I'm chatting with a doctor about caffeine." Oh, I'm going to listen to that. I'm not going to enjoy it. And I said, "No, this is good because actually it's a really positive thing." But it's funny, isn't it? We're talking with a doctor about caffeine. Oh, that's bad. We instantly go to that negative, don't we? It's funny.
Well, I'm very pleased that something that we all enjoy so much actually has mainly good sides, except if we go into excess, which we discussed last week.
Yeah. Great. Okay. And moving on to today's subject, then we're going to change tack slightly. Go for it.
Yeah. So we've been last couple of weeks and carrying on today, we've been looking at topical subjects, if you like, subjects in the news where there's been some recent research making us think. And again, over the last few days, I've come across something on gene editing, which we're going to look at, and how it affects two particularly important diseases, not that affect us all, but which affect a considerable minority of people. And we're talking about blood diseases, sickle cell disease, and thalassemia. So this has been in the news because we're looking hopefully for a cure from altering dysfunctional genes in these diseases. Now, I say it doesn't affect all, as absolutely it doesn't, but there's a considerable minority in both the UK and the US who have sickle cell disease and thalassemia. And what we're looking at really is there a way to abolish these nasty diseases? And it's very early days, literally just been published in the last few days, but it does seem to be highly promising. So what I wanted to do today, because there's quite a bit of science here, is to, if you like, summarize what's going on with these diseases and where we're at currently. And then next time, look at this new technique, which will actually, and next time will be in a couple of weeks' time, as I'm away next week. That allows 2 weeks more in the press to give me a bit more to get my teeth into, because literally this is hot off the press. In fact, I spoke to a psychiatrist yesterday who hadn't heard. And I said, "Oh, this is check out your newspapers." He hadn't heard. So it really is hot off the press. So what I thought we'd do in next time, if you look at the implications of the new research in terms of cost, ethics, and the Bible, but let's just look at the diseases themselves, if you like, the problem to start with. So sickle cell disease, which I think most people will have heard of, causes sickle cell anemia. And this affects 20 million lives, particularly in West Africa. And here's what I learned. In the UK, there are 17,000 people with sickle cell disease who will be descendants of people from the Africans originally. I've even got a paediatrician who's a friend of mine who works in the Midlands. This is her specialty, sickle cell disease, because there are so many people in her area in the Midlands with sickle cell disease. So that's absolute specialty. And the disease is interesting, not just because it's nasty, but it seems to confer some benefits too. So bear with me, where are we going on this one? So let's look at the bad side of sickle cell disease. Essentially, there's an unhelpful gene affecting the hemoglobin molecule in our red blood cells. So our red blood cells, hemoglobin carries oxygen. That's what oxygenates us. But there's a gene affecting the hemoglobin molecule, and that causes the hemoglobin and the red cells and the red cells themselves to become deformed. Now, normally, you have to try and imagine, because I can't really draw it on the radio, red blood cells are what we call biconcave. So they're not like a sphere, like a football. They're the other way around. They're concave on both sides. They go in on both sides, and they're flexible. That's how the red cells have been designed. But in sickle cell disease, they switch from being biconcave to being sickle-shaped, like half a moon. So they change shape, and probably more importantly, they become rigid. So we've no longer got this flexible biconcave shape. You've got these rigid sickle cells, and therefore, because they're rigid, they don't flow through small blood vessels like normal red blood cells do, and they get stuck, and they block the blood vessels. And that damages organs and is extremely painful. Just imagine if you blocked a blood vessel to your finger went white and then ultimately died. Extremely painful, because the tissue is crying out, "Where's my oxygen?" And it's been blocked. So people get awful sickle cell crises, and they can be severe enough to threaten life, not just be painful.
Wow.
And indeed, in sickle cell disease, life expectancy is down to about 47, 48 on average, even with good treatment, because of the organ damage that takes place. Kids are more vulnerable with sickle cell to infections like pneumonia, much more vulnerable to getting strokes, as well as organ damage, again, from blocked blood vessels. The spleen enlarges. The spleen, one of its jobs is to mop up old red blood cells. Well, damaged red blood cells get mopped up. So they get anemic, it overacts to remove these damaged cells, the spleen enlarges, and then it becomes part of the problem, contributing to the anemia. And you've got this sort of bad a vortex going on, really. And you get these crises in sickle cell disease, which could be triggered by cold weather, getting dehydrated, other infections, so bad that people need to be hospitalized often. So that's the bad news. But there is a bit of good news with sickle cell, interestingly. In Africa, as the body attempts to remove these damaged sickle cells, some of these cells have got the malaria parasite in them, because that's what malaria does. It enters the cells and causes its trouble that way. So the body is also removing malarial parasites along with the damaged cells. And there's a man called Dr. Tony Allison who did a lot of work, and he showed that kids with sickle cell in Africa had a lowered malarial parasite count. It seemed to have a selective evolutionary advantage in having sickle cell. It was bad for you, but it also reduced your malaria. Perhaps that's one reason why it's persisted. However, it's not quite as simple as that, because if you get a nasty malarial attack, it can also trigger a sickle cell attack and increase your mortality. So it's not completely simple, but there's no doubt that it seems to convey some advantage in Africa against malaria. So that's the picture, really. The disease can vary in severity, and that depends on whether you get one gene from one parent or sickle cell gene from both parents. So we call it homozygous or heterozygous. You have sickle cell carriers, where they carry the gene but don't suffer the disease. So it's quite a complicated picture. And we got this new excitement in terms of, well, could we, rather than just treat sickle cell, could we prevent it? And that's where the gene editing comes in. That's what we'll look at in a couple of weeks' time. Because at the moment, all you can do in terms of, okay, can we really go for this, is bone marrow transplant. And that means you're replacing the abnormal cells in your bone marrow with normal cells from hopefully your brother or your sister. And of course, as with all transplants, you have enormous implications in terms of drugs and ongoing treatment, being hospitalized. Oh my goodness, it's a long business. How much better if the disease could be sorted out once and for all, if you like, at source. So there we have sickle cell disease. I don't know if you want to come up with any questions, Andy, or we'll look at thalassemia first, and you can chuck in your questions at the end.
I was going to say sickle cell. It's one of the ones I have heard of, because I had quite a few friends growing up in Wolverhampton. It was a very multicultural city, and I had loads and loads of black friends. And so it was a conversation that would come up sometimes, because some of them suffered. One guy in particular, and his was his face. He got really, really bad pain, and he said it's sickle cell. So I suppose one of my assumptions was this is something that affected, because this is what they told me, that as a black community they were affected more than white. Is that right?
Far more, yes. Very few whites, actually, because it is predominantly a West African disease, and descendants from there come to the UK. And absolutely, it's I'm afraid very much a black person's condition because of inheritance.
Yeah. Okay. And you were saying there's about 17,000 people in the UK. But one of the things that really threw me, though, is I never thought it would have ended up in hospitalization and a much shorter lifespan. You said 47, 48 years was kind of a life expectancy with sickle cell. That's something that actually I found quite shocking. I had no clue about that.
Yeah. I think there's about 100,000 plus in America as well. For our friends across the pond. But it's a significant disease. It's not affecting everybody, but it's affecting a lot of people.
Yeah.
And so yes, and it's both unpleasant and increases your mortality, reduces your lifespan.
The rigid thing, again, that makes some sense to me, that if the cell is going to go from being sort of floppy and flexible, where it can move through gaps, if it's now solid, it's going to end up, it's like a drain, isn't it? It's going to get stuck. They're going to get together, and I can understand that. And I can understand how that would then cause pain, because obviously your body's then in distress, isn't it?
Absolutely. Oh, severe distress. It's a really nasty, painful condition. And people have to have morphine, serious pain drugs because it's so unpleasant until the crisis is over.
So it's something that it's a sort of a cyclic thing. You can have a good day and a good week, and then it will come back at you.
Yes, there are triggers. Other infections can be a trigger if you get dry, and therefore if you have less fluid in your blood, the cells are much more likely to block small organs. So getting dry is a major problem. Cold weather, bad weather can really, especially in the UK, obviously can trigger sickle cell crises. So there are various triggers, and sometimes you just don't know why. It's just happened.
And I think I heard this right. You said that bone marrow. I understand the very simplistic version of it, which is that you take bone marrow from one person and you put it into another person. Did I hear right? That's pretty much the only way of dealing with this at the moment.
At the moment, other than of course treating the problems, treating the pain, fluid management if someone is dry, treat the other infections. But yes, in terms of if you like, it's not so much cure because it's an ongoing thing that you have to do more than once. Bone marrow transplantation. So that's where we're at the moment. How wonderful, rather than having to wait for problems and further down the line you get your bone marrow transplanted, how wonderful it could be dealt with much earlier on through gene editing. And that's what we'll be looking at.
Fine. And then thalassemia. Did I say that right?
Thalassemia with a TH. Thalassemia. Indeed.
Thalassemia. Okay. So what's that? I've never heard of that one.
Right. Well, this is another blood disease which shares some similarities with sickle cell disease, which is why the gene editing hopefully will apply to both. It's a cause of anemia. So again, not enough red blood cells. It's more widespread than sickle cell disease. It's in Africa, it's in Asia, some European countries. And indeed, one thing I just got reminded by looking at my screens was that it's named after Thalassa, which in Greek means sea, because it was discovered around the Mediterranean Sea. So thalassemia, if you like, is sea anemia, because that's where so many Greek people will have thalassemia. And again, it's a hereditary defect in the synthesis of hemoglobin. You get an abnormal shape, or they're not as marked as with sickle cells. You get abnormal size, abnormal color of cells, just not enough hemoglobin. And as with other anemias, it makes you tired, fatigued, weak. And the treatment is blood transfusions. Once your hemoglobin drops to a certain point, blood transfusions are needed. Again, the spleen enlarges. And one of the problems when the spleen enlarges to get rid of damaged cells, it becomes overactive. So even when you transfuse someone, it can get rid of normal cells as well. And so the lifespan of blood cells is reduced. Normally, red blood cells last on average 120 days, but they're not lasting as long in thalassemia. And the anemia continues. And when I have look at my thalassemia patients in practice, because there's lots of thalassemia patients we have, often in the minor range, which we'll come to in a second, they've always got a low hemoglobin. That's standard. And in fact, they get used to it to a large extent. But what's going on genetically? Well, there is, again, an abnormal gene that at least one of your parents must carry. They don't have the disease themselves. They're referred to as carriers in order to pass it on to their children. And some of them are referred to as having a genetic trait, TRAIT, which means they've got the genetic mutation but don't have the disease, or maybe just mild symptoms. So they have a normal lifespan. So right at the lower end of the range, you've got people with a trait, but their lifespan's not really affected. Now, unlike sickle cell disease, here's the difference. There's different types of thalassemia because it's actually a group of related conditions. It's not just one condition like sickle cell. You have alpha and beta thalassemia, and you also have minor and major. So we'll just summarize these very quickly, really. The alpha and beta, within a hemoglobin, you've got alpha globin and beta globin, which together help to make up your hemoglobin. And in alpha thalassemia, the defect is in the alpha globin and beta in the beta globin. Minor, well, again, you've just inherited one abnormal gene from one parent rather than abnormal genes from both parents. And you've got a 50% chance then of passing it on to your kids. If you inherit the faulty gene from both parents, then you've got a chance of having major thalassemia. And that really matters because it's the major ones that we'll just briefly talk about now and that affect life expectancy, to the extent that with the alpha thalassemia major, many children don't even survive being in utero. They're born dead. It's such a severe disease that these children sadly don't live. So the beta thalassemia majors are the ones that we see more in practice. Again, can affect your lifespan considerably if not treated. People die by 30. With treatment, you can live into their 50s, 60s, but that means regular transfusions. And the thing here is there's a double-sided sword here. One is low anemia, low hemoglobin, so anemia. Okay, we can replace that with blood transfusions, but within the blood is a lot of iron. And we know that people who are anemic in this country often it's due to low iron. Problem with lots of transfusions is the opposite. You get excess iron, and iron in excess damages your organs, heart, your liver, your lungs, other organs. People end up with cirrhosis in the liver, scarred, damaged liver, which can then lead to liver cancer. More recently, more cancers have been linked to thalassemia, leukemia, lymphoma. So it's a big problem. And again, hopefully people can live to 50 or 60 or so, but it's a big problem with a shortened lifespan. Wouldn't it be wonderful to, again, knock it on the head right at the beginning of life through gene editing? And the other interesting thing with thalassemia particularly is, well, it's got implications for marriage. Should you check out your girlfriend or your boyfriend in advance? What's your blood doing? Oh, right, my goodness, because actually you're also a carrier, or you've got the disease. What does this mean in terms of genetics for any potential children? Big issues here. So that's really the science behind both sickle cell and thalassemia. And as I said, next time what we want to look at is, okay, what's gene editing got to offer? Very new research. What's being suggested? How will it help sufferers? What are the costs? Interestingly, in my in the Times newspaper on Monday, it was saying the costs are likely to be at the moment £1 million per patient for a sickle cell disease. But as with all these things, the costs will go down as research produces the treatment, and the treatment costs go down. But it may well still be in the hundreds of thousands per sufferer. Can the NHS afford it? Is it the best use of resources? We have all these sort of ethical questions. But also, what does the Bible teach us? As Christians, how should we be responding to a disease like sickle cell, like thalassemia? I haven't seen the costs on thalassemia, but one would imagine it would be similar, because we talk about editing genes, and that's very much at the beginning of where we're up to at the moment with these diseases. So there we are. We've got big problems and a potential solution. And next time, I think we'll have a look at what the research is saying about gene editing, and hopefully the listeners will have their own questions, because this is a massive area for ethics. This isn't just about technical expertise. This is about ethics.
Well, as soon as you say, well, if I marry this person and we have children, we're going to potentially create a problem, therefore let's not get married, you're immediately into ethics, aren't you?
Gosh, absolutely. Yeah.
And then it's down to, value of life. And I did one super tiny module of ethics when I was doing Christian theology A-level. And it just blew my head when you can ask such a simple question, and yet the ramifications are far, far wider than we could possibly immediately assume.
Absolutely. And with a finite budget, hip replacements matter. Is it more important to have a hip replacement or to have several hip replacements, a lot of hip replacements, or one person with sickle cell disease having their life altered? It's a tough one, and I'm very glad that I don't have to make these decisions.
Yeah,
but it's important to think about them and to bring them up. And also, as Christians, what has God got to say? What does the Bible teach us?
We either believe God's got an answer or we don't. And if he's got an answer, he's got an answer for everything. Otherwise, he's not God. Therefore, there has to be some biblical place of peace for our minds, I suppose, is how I'd word that.
Absolutely. I mean, just I angled with that. I mean, we know that all diseases are a result of the fall of man.
Yeah.
That's where, and there won't be any disease in heaven. But here we are on earth within a fallen world as fallen people. But thank goodness that God also gives us brains and the scientists, wonderful scientists, wonderful brains to find some solutions along the way until Jesus comes again.
One question that does jump at me, though, is sickle cell anemia. I've heard of it. I don't know whether that's because I grew up, a lot of my friends, people I would be with, were part of the Black community. Therefore, that was a normal part of their conversation, which I was then a part of. But I'd not heard of thalassemia, which is actually, you're saying, kind of more, not common, maybe isn't the right word, but it's more widespread.
Oh, well, that's, I guess I'm in the field, so I hear about it. It's certainly one
Yeah.
of the diseases we were taught about at medical school, along with sickle cell. And as a GP, I don't see many sickle cells, not in my area, um, but I do see quite a few people with thalassemia, and most of them are actually pretty well. Perhaps I see them at the lower end, and certainly when people are bad, of course, they go to hospital rather than to general practice. But everybody is anemic, and it certainly has an effect on their families. And although many people are well with thalassemia because they have thalassemia minor, those with thalassemia major, it's major,
Yeah.
and it's well named for a reason.
Yeah. No, that makes sense. I'm looking forward to understanding what gene editing is, because I have no concept. That'll be fascinating. Whatever you say will be new to me, which is great. But I keep on saying this, every day is learning day, because the more we can learn about these things, the better we can get on in life with each other and all that stuff. And if we have no knowledge about something, I mean, that's where fear comes from. Sometimes we don't know about something, so we fear it.
Yes.
And actually, sometimes just understanding it can be can be a reduction, or even make the fear go away completely once we understand what's really going on. I've heard of people who have been given that, death sentence of you're going to die, you've got a terminal condition. And I've heard it a few times. I say, well, we've all got terminal condition. We're all going to die. We just know we're going to die earlier. And it's interesting how they can sometimes find peace. I mean, our friend Steve Legg, who was given a terrible diagnosis, you've got months to live, and yet he's embraced life through that. And that is a difference that I think, with all some of these shocking conditions that can exist, actually, there's still hope. And that I think is a really good place to end, because no matter what's going on in your life, there is still hope.
Absolutely. And, part of that hope is, yes, people raising money. I was just reading about Doddy Weir, the rugby player, who died from motor neuron disease, and his wife was part of, raising money and awareness and helping scientists move forwards to help other people. Absolutely. But what about the individual sufferer? Absolutely. You're quite right, Andy. We need to have, each person needs to have hope. And ultimately, we will all die from something, whether it's heart disease, thalassemia, sickle cell, whatever. We have a lifespan. Which God holds in his hands, and how can we live as well as possible during that time? And that's absolutely where Christian hope comes in.
Amen to that. Right, I can't think of a better place to finish than the Christian hope. It doesn't get any better, does it? Thank you, Richard, so much. If you've got any questions for Richard about anything you've heard on today's show, last week, or any other comments, topics that you've seen in the news, do send them through to me. I'll pass them on to him. hello@pure247radio.org. That's the email. hello@pure247radio.org. Email them to me, and we'll put them to Richard to answer you on air. And you can be as anonymous as you like. You don't have to put your name in. That's absolutely fine. We understand that. Thank you, Richard, for another fascinating time. I'm looking forward to gene editing. That is going to be really interesting.
Andy, it's always good.
Thank you.